Now let's talk about virulence versus pathogenesis. Now, what I really like about epidemiology, it's such a fun field because nobody can agree on anything. Like in terminology, people would use different terms like transmission or transmissibility. When doctors or public health experts from, say, CDC or even general public use the term transmission, they actually talk about the spread. Do you see the difference? So spread is how disease spreads in the population. For a pure virologist, transmission is a process when pathogen leaves my respiratory system and gets transmitted to your respiratory system. That's it. How far does it go? How stable it is in the air? Does that make sense? That's transmission for a pure pedantic virologist. Okay? This is why it's so nice to talk about these things. So, let's talk about virulence versus pathogenesis. Pathogenesis, plus minus, basically qualitative. Okay? And by qualitative, we can say, oh, this virus is pathogenic. Okay, this virus is non-pathogenic. So let me explain. We have 4 common cold coronaviruses. Okay? Now we have SARS-CoV-2 as well. So we have 5 coronaviruses circulating through the human population right now. Are you with me? All 5 of them cause disease, which means all 5 of them are pathogenic. Am I clear? Now, virulence determines the severity of disease. So, for instance, coronavirus OC43 will lead to a garden variety common cold. Does that make sense? SARS-CoV-2 causes in many people, causes much more severe conditions, and you may end up like on the ventilator. Does that make sense? OC43 and SARS-CoV-2 are both pathogenic, but SARS-CoV-2 is more virulent than OC43. Does that make sense? Are we clear? Okay. Now, what determines the virulence? Virulence is determined by various virulence factors. And virulence factors can be from the side of the pathogen, well, I'm sorry for this. Let's rephrase this. It's not virulence is determined. Is determined by, okay? So it can be determined by a pathogen, it is determined by a pathogen, and it is determined by a host. Okay? Does that make sense to you all? Sorry about that, but you will see why I changed it. So, on the side of the pathogen, what determines the virulence? Portal of entry. Okay, if you spill coronavirus in the skin, nothing's going to happen. Inoculation dose. You see I put a big question mark? This is still a debated issue. And that's important. I want you to understand the difference between it's not like this versus you don't have data. We don't have data that would suggest that the dose of SARS-CoV-2 would determine the severity of disease. We don't have data. We don't know. Maybe it does, maybe it does not. I know that many virologists and doctors believe that it doesn't. It doesn't matter how much you get in. Does that make sense? Okay. Now, good example of portal of entry and the inoculation dose, rabies, one of my favorite viruses. If somebody gets one bite into a leg, okay, it's going to take longer for this, assuming that the person does not get any treatment, it's going to get longer for that person to die. And the death is going to be slower. So virulence is different. That makes sense. If the person gets multiple bites in the face, we're talking about sometimes a couple of weeks until succumbing to the infection. Because much larger dose, different portal of entry, much closer to the brain. Does that make sense? But perhaps the most important factor that determines the virulence on the pathogen side is the virulence factors. We're going to talk about them. Okay? And in terms of the virulence, there are multiple. Okay? Now, in the host, so immune status, I take it generally. Now, immune status, look, it can include whether you are immunocompromised or not due to the treatments, whether or not you immunocompromised due to the fact that you're old. You see what like it's all immune status. Nutritional status, which kind of repercusses with immune. Overall health. I can give you one. Look. It's an example that isn't coming from infectious disease point, but you can translate it. So I'm going to give you a question. There was a study looking at the outcomes of cardiac surgery in obese patients, like really, really severe hardcore cardiac surgery, in obese patients versus normal weight patients. Which patients will have more chance, higher chance, to survive post-surgically? Which ones, obese or normal weight? Obese. They have more to lose. People often can't eat, and normal weight patients, they can't consume food, they lose weight, they become nutritionally deprived, and their survival rate's actually lower than patients with obesity. I'm talking like post-surgical, not 5 years, post-surgical survival. So we have a Russian expression to this, but I can't translate it in English. So basically, think of it this way. If you get infected with something that prevents you from eating for like 2 weeks, and all you can do is drink, if you have some extra, you can spare it, you know? And if you're a twig, sucks to be you. Previous exposures, of course. And genetics. Okay, now, previous exposures, whether or not you're immune, genetics. There are multiple, so there are studies even for coronavirus now, associating certain genetic differences, certain intrinsic alterations to more severe course of infection. Does that make sense? Good? So I want you to basically be, and for this one, I want you to be able to kind of answer the question, like which of the factors is contributing on the host side, which of the factors is contributing on the pathogen side. Does that make sense so far? Okay, good.